Welcome to this webinar, In-Depth Surgical and Restorative Guidance for Full Arch Rehabilitation. It is being presented by Jeff Carlson, CDT, and we will begin shortly. And with that, it is my pleasure to introduce Jeff Carlson, CDT. He is a senior in sequence implant specialist. Jeff Carlson has extensive experience in both the dental laboratory setting as well as working with dental implant manufacturers in the areas of education and technical and sales support. He has lectured both nationally and internationally on dental implants. Jeff is the primary author of a 300-page, fully illustrated cookbook for restorative doctors and is a co-author of a corresponding restorative manual for auxiliaries that has been distributed in 8 countries. Jeff has also developed a 2-day training program helping clinicians improve their presentation skills, which has been attended by more than 200 dentists from 16 countries. And now I get to say, take it away, Jeff.
Well, I thank you very much, Jessica. Hello, everyone, and welcome. Good evening. Really do, again, appreciate your time this evening. We're going to be sharing a lot of information. Those of you that have viewed some of my programs before, be it live or maybe in this format, I've tried to add some new content, go a little more in depth on some things. As Jessica mentioned, we are recording it. So I think it's a great opportunity to review, come back and review again, because there will be quite a bit of information. So without further ado, let's get right into it. So first, I do need to make my couple of disclosure statements. I am a full-time employee of National Dentex, so I'm compensated through them as a full-time employee. As far as commercial support, I was compensated and for the development of this presentation, be it the documentation of the clinical information being shown, as well as putting the program together. So what are we talking about here? This guided surgical, guided prosthetics, really what I like to say it does, whether it's the specific technique that I'll be sharing with you this evening, or some that are somewhat similar, is that this level of technology really helps to minimize variables. And I feel it's being done through science and because of a very systematic approach. If anyone says they can eliminate all the variables and make it, fast, easy, simple, I would probably say walk away, because we're going to share with you a lot of information of how we do a lot of planning. Very important. The records that we are capturing are so critical to the success of this type of treatment modality. But really, it does really help to minimize the variables, but there's no way possible that anyone can eliminate the variables, no matter what level of technology that you're getting into. So what sometimes I find people are very surprised about is what it takes to do a case following this type of treatment protocol. And it's really fundamentally, there's 5 pieces of information that needs to be captured and submitted into the laboratory. Obviously, one is the CBCT scan. We work off of CT scans. The other is going to be we need to have the vertical dimension of occlusion established. So we need that along with their bite registration, your centric occlusion, be it CRCO. Some refer to it as your MIP, your maximum intercuspation position. So simply we can just say your bite at the correct vertical. The other thing is we do need full arch documentation of the arches. Can be done with digital protocol or analog protocol, where you can utilize, and we'll talk more about each one of these as we move along. There are photos that are absolutely required, and you're going to find the importance of these photos in the presentation. That's really going to help us to meet your expectations and your patient's expectations. And then the 5th piece of information really is the prescription. There's an online prescription that has drop downs that will ask a lot of questions. As you can imagine, this isn't just about getting a shade and being able to read margins. and have it capture a bite, but this goes very in depth because we are reconstructing either a full arch, and in many cases, we're reconstructing the full mouth with this type of treatment modality. So it is nice that we have, there was kind of minimum information needed. Very specifically, the way that we're going to capture it is very critical to success, as I mentioned, to this type of treatment. So let's talk about capturing the records and what are the required records for doing this. And I would like to say, too, that regardless of what company you're working with, laboratory you're working with, the records are very similar that's needed. And the level of quality of these records is also very critical. Guessing at things is not very smart to do when we're dealing with this type of treatment. So we do have some quick reference guides that are available, PDFs that can be downloaded. And these are like cheat sheets, if you will, or cliff notes of what I'll be sharing with you as far as when it comes to record taking. So kind of a close-up look here. This is the back side of one of them. This one happens to be for the fully dentate arch. You see 4 steps here. The 5th step is the prescription. But it's snapshots, just as a quick reminder to make sure you're getting all the data captured for you. So sometimes people think, wow, this is great. I have these five easy things to do. And now, we're off and going to the races. And unfortunately, sometimes, you're not ready to run the race. You're on the right track, you're getting there, but we need some more information to really complete the process, if you will. So let's go into more details of each one of these requirements. So let's start first with the photos. There's 5 photos minimum that we're looking for. And I wanted to stop for a moment and talk about a very important one, and that's going to be the high smile, capturing the high smile. Now, where some clinicians make the mistake is they'll ask a patient just to smile big and take that photo. And as many of you are aware, a lot of these patients that are looking for this treatment as an alternative for them is because of aesthetics. And they've learned over time to do what we refer to as a guarded smile. You can say smile big, and they learn to smile big. You go, no, real big. And sometimes they just get taller and they're smiling big, but they're not showing the teeth. And so those of you that are familiar with the Duchenne smile, that is a smile that has takes a patient to where the upper lip goes to its maximum height possible. Many people will say basically just like a real squinting smile. How big can you smile for us? The point that we want to have in this image is that we want to see physically how far the patient can bring their maxillary lip. The reason for that is there's a very important thing with this type of treatment is to where do we is the position where the prosthesis meets the alveolar ridge. So where the position of the teeth meets the alveolar ridge needs to not be shown in the smile. And so we need to see that physical portion of it. I'm going to get into more details with you as to how that has to do with our bone cut as well. And maybe even with the choice of the final prosthesis that you're electing for your patient. So that's something I want to talk about, that high smile line. And it's not just a big smile, but it's really get that smile as large as you can. And then the lips just parted and relaxed. We're looking to see that as well. And again, we're talking about these are minimum photos that we're looking for. The other 3 images that are required are going to be in occlusion. We want a retracted frontal, retracted left, and retracted right. And this is for a couple of reasons. It's going to help us to cross-validate, which is something that is done extremely often. We cross-validate between digital data and analog data. In other words, we look at photos, we look at models, and we hold things and look together to say, does that look the same? Is what we're seeing, what the doctor is seeing clinically, or in the practice, if you will, the same thing that we're seeing holding models or looking at the impressions, et cetera. So this gives us the ability to look at whether or not we're the occlusion might be. You might notice a patient might be more of a class 1 or class 3 even. And if the photos that we get, those doesn't seem to match what we're seeing in the models or from the bite registration you send us, you're going to get an email saying, okay, doctor, which one should we be going with? So these are minimum of 5 photos, more is better. The other thing about the photos is we're looking for not much more than just a couple of a couple of inches past the ears, below the chin, and above the forehead. We don't want to get a photo of a patient that's 8 feet away. These photos can be done with your cell phone. It works perfectly well doing that. But we want to be able to get good clarity too as we zoom in at the laboratory and are looking closer at these photos. So when it comes to impressions, we can receive digital impressions as well as the analog. And I want to go into a little detail on both of these because there's definitely some do's and don'ts with each one of these. So let's talk first about analog impressions or your PVS impressions. One of the things that you really need to think about, whether it's you as a clinician impressioning, I'm going to get to the digital in just a moment, but I'll bring it up right now. If the assistant, many times the assistant might be taking impressions as well, be it PVS impressions or Elgin impressions, or doing the digital scanning. But you want to think that you want an impression for a full denture. Even though we're going to be fabricating you a provisional bridge and your final restoration will be a bridge, we want to ask that you do a full impression for an immediate denture. The reason for that is that way we can fabricate for you a backup denture. And that's extremely important. Patients are paying a lot of money. They have high expectations. And even though we're doing so much due diligence on your end, on our end, to ensure that between drilling protocols and different techniques, some of the great implant system that you're working with, the companies we're working with, getting immediate stability is not 100% guaranteed. And if you're not able to load those implants the day of surgery, the patient is expecting to leave with at least a smile. So to fabricate a backup denture, we do need to have all the anatomy. So we want to see the palatine fovea. We want to see the hamular notch, retromolar pads, the peripheral borders. Again, think like it's a denture. So it's very important for that. If we get a scan, an STL file, let's say, and we can't read it, you're going to get an email saying that we cannot fabricate a backup denture. We will not move forward until you sign a waiver saying that's fine, I accept that. If the day of surgery, if you needed a backup denture and you don't get one, it could be upwards to 4 to 5, maybe even more business days before one could be fabricated and sent to you. And that could put you in a very difficult position with your patient. So keep that in mind. The quality of the impressions. So if you're doing are very important. So if you are doing the iOS technology and you're scanning, as you know, that those of you that are doing that fully edentulous or the soft tissue area sometimes is hard to pick up. I know a lot of you want to be all digital, but the reality is this: we are still not there. The digital technology is not there really to be 100% digital. For the accuracy and to the details that we need to provide you and your patients with a product that's going to meet your needs and provide a safe protocol, we need to have the very good quality information. So you may need to also send in a PVS impression along with your scan, just as a backup. If you ever wondering to yourself, well, I wonder if I should go ahead and do an impression as well as the scan. If you're even saying that to yourself, having that talk track, just do it. That's your inner being telling you you should be doing it. So let's talk a little bit about the digital. So in scanning, regardless of what system you're working with, one of the things is that, as I mentioned, you want to scan the entire arch, the palatal area, the entire lingual borders, retromolar pads, etc. There's most of the units today have artificial intelligence set up with them. And there should be a button where you can click and turn off the artificial intelligence. And we suggest that you do that. And the reason is that that's going to really not capture some of the details that we are looking for to fabricate that full denture as that backup denture for you. So that's one thing, is to turn off the artificial intelligence. The other is not to have the scans trimmed. And what we mean by that, it wouldn't be something necessarily that you would be doing. Rather, the company that you're working with, who receives your scan before it's sent to the laboratory, many times they are trimming the scan. And what that means is they are removing, they look at this, you're making a bridge. So they're going to remove the palatal area. They'll remove some of the borders. They remove a lot of the pink. These are pixels and voxels that are taking up our data, and they slow the software down. So these scans will be trimmed so that they can be manipulated more rapidly and more efficiently within the software. Well, we want to receive the full scan. We will capture that, we'll note that, we'll document that full scan. Then we will go ahead and trim that scan to meet the needs of the software to be effective in running it through the programs. So hopefully that helps you with your scanning. There's something else that I would like to talk to you about when we're talking about the digital scanning, and that is when you're taking a digital bite. Where we've been seeing some issues internally at the laboratory, we refer to this as being, we call it cast collision. I don't recall seeing this written up in any articles anywhere, but let me explain what that is. Cast collision in the real world, if you will, the physical world, the analog world, you cannot have two objects occupy the same place at the same time, two solid objects. It's not possible. However, in the digital world, it's possible. So what you're seeing here is you're seeing where the highlight here, kind of the purple pink highlight, is showing where the two arches are going in through each other. And the reason this happens is because when who's ever doing the scanning of the bite, it's a very specific movement of the wand to do that. I would recommend, if you've not done scans for something like this, or for bites, or if you're newer to it, the manufacturer working with, they all have really great training videos. YouTube, there's a lot of things available on YouTube as well, but there's some very specific protocol for where you start, how you move over to the occlusal to start capturing the lingual or the palatal side. And what we find happens is when that's not done correctly, the software has an issue with stitching the records together. And that's where we get some in these discrepancies. So in this scenario, if you see this happen on your screen, you can try scanning again. That often works. If not, go ahead and still take a physical bite registration in conjunction with the scan. That way we have two references that we can go back and forth to. For the impressions, PVS material is preferred and recommended because of its accuracy. Of course, we know that many of these patients who are accepting this treatment, they have very mobile teeth. And many times the impression protocol or procedure, you could end up doing the extractions. So it's fine to do an alginate impression. Again, it's preferred, if you can, to do with PVS impressions. Quick little tip for you: when you have patients that have very pronounced, very deep interdental embrasures and a lot of undercuts, if you will, because of periodontal disease, because of bone loss, especially with PVS material, it get in those undercuts and lock in. Blocking out is very important to do. I've used putty many times, the bright color Play-Doh, I should say. However, I've also found that just using wet Kleenex, moist Kleenex, works well to pack in there, and it stays quite well, and it's easy to remove. If you miss anything, there's no harm or no foul to the patient. So I just kind of wanted to share that with you as well. Custom trays, not required, but again, to the level that you want to have as much information for us, the better. So I want to talk now about some of the scanning protocols. So hopefully you're feeling pretty comfortable about the impressioning protocols. So when it comes to the CBCT scanning, what you're looking at here is actually a kind of the raw data from a DICOM. Your CT scans, when they're uploaded as a DICOM file. And so then at the laboratory, these files are going to go through, and our segmenters, we're going to start going through. They go from where the soft tissue, they keep going through density until they get into the alveolar ridge and start, actually segmenting your case slice by slice. And we'll take a look at that a little bit more detail. So when scanning, we know sometimes that patients move, and that's where we get what we call the, like distortion, a blurry scan here, as you see on the right, maybe from a patient moving. Scatter is a challenge, especially at patients that have a lot of metal in their mouth. If they do have a partial and they have the metal, the metal saddle and the partial, the meshwork and clasp and eye bars and et cetera, if you, it may be necessary, if that's the arch we're working on, it's not just the opposing arch, but that's actually going to be the working arch, to remove the partial and utilize occlusal rims at that same vertical with radiographic markers in place, which I'm going to show those coming up, just to make sure that we have such clear, accurate data. It's extremely important. Many of these cases, because these patients, I don't mean this in condescending to patients, they're not good patients. What I mean by that, dentally, physiologically, there's a lot of bone resorption. Sometimes we're placing implants in the very narrow ridges, and we're just getting in front of the sinus. We're getting, very careful where we're being around the mental loop, the mental frenum, et cetera. So accuracy of the scans are very important. If you're ever wondering if your scan is accurate enough, the quality is good enough, we offer something called a scan review. There's someone from 7 a.m. Pacific time till 5 p.m. Pacific time at the laboratory that can, if you upload the file, call the laboratory, let them know what you're wanting to do. It takes anywhere from about 15 to 20 minutes. And they're not going to tell you if this patient is a candidate for this treatment. All they're going to do is to be able to tell you if that scan that you've uploaded has the good enough quality that we can work with that scan. It doesn't mean there's still a patient, a candidate for this, or that about bone densities, et cetera. Strictly the quality of scan. That way, you haven't had a patient leave and drive 2 hours back home to only find out a couple of days later that your scan isn't any good, and now you have to bring a patient back. So keep that in mind. That's available. So to help get good quality scans, what we found as far as the resolution setting, and based on your unit, it may be a little different numbers to dial in, but what we found is that something as close as you can to a 0.3 voxel resolution at about 20 seconds really gives the ideal. It captures the quality of the data and still functions very well within the software. And we really, again, strongly recommend that you as a clinician are also validating and looking at these scans before they're sent. It's surprising really how many times we'll get a scan, we'll reach out to the doctor, and the doctor say, you know what, I didn't even check it, I got busy with another patient. We understand that, but please understand, there's a lot of times we will not accept records, and because we know, not from a position of arrogance, but from a position of knowing. We've been doing this technology since 2009, and we've done tens of thousands of cases. So we know what's needed to be successful for you and for your patient. If you ever get asked, if you're asked for something, new data, better scan, new impressions, or whatever it is, and you say you're not going to provide it for whatever reason, the point is, if you're asked to sign a waiver, you should really pause and think, why am I being asked to sign a waiver? Because we're doing it because we know what we know, and really take that to heart, because that's a very important thing for you to be making a good judgment call on. When it comes to the field of view, there is really a minimum of field of view of 8 centimeters by 8 centimeters. Your systems, different systems have different settings. That's kind of our target. You know, we really like to see a little bit more. If we can get to that 10 centimeter by 10 centimeter, it gives us more data. It sometimes can actually give us what we refer to sometimes as a digital face bowl, when we can see the condyles in relationship. We have that data, we have photos. So it really helps to give us some more information to extrapolate from, for us to help make good decisions, again, for the optimal outcome for you all. Something about these scans about movement, it does happen. When we find that sometimes the patient movement is something gets missed, maybe by the assistant or the clinician, whoever is doing the scanning of the patient. We know that you or your assistants are very careful, you know, watching how they're holding their hands, where their shoulders are as the unit is passing through, passing around the patient. But what sometimes happens, I'm gonna do this kind of exaggerating a little bit, is that patients can be very nervous, especially some of the elderly patients. They have a loose facial mask, and what you're not seeing is they're doing possibly this. They're like, they're shifting and grinding, they're kind of like grinding their teeth away, they're just kind of nervous, and that may not show as you're looking at them from 2 feet away. So if you have a patient, sometimes patients who have Parkinson's, that can also be a bit of a challenge. So this is a technique, it's not 100%, but it can help in many cases. What you do is utilize blue mousse, is actually probably the most rigid elastomonomer bite material, but you want something that's very rigid once it's set. And do a occlusal bite registration and capture, you know, the down onto the buccal, over the buccal third, if you will, of both arches. We're looking to actually, I kind of rephrase, I coined the phrase, at least I think I did. I haven't seen anywhere else, so if I didn't, I apologize. But in my mind, I came up with this phrase, a positioning jig, a scanning positioning jig, if you will. What I mean by that is that helps to the patient, you tell the patient to bite in that during the scan and just stay biting onto that. It's really helped to reduce a lot of that side shifting that the patients might do, and to bring down some of that blur. So think about that, might help you out on a case. Now, when you do that, because you've scanned the patient with that bite, some people might think, well, that's not good. Now the teeth are apart. Well, this is actually a protocol we've done for many years, where we wanted a bite registration, the patient taking the bite registration in place using the chin rest. So we are able to utilize this, as you're seeing in the photo here, where the patient's on a chin rest, bite registration in place. You just do not use the bite fork for that scenario. If that wasn't the scenario, then you can have the patient in occlusion and have them utilizing the bite fork, biting onto that bite fork, and then scan as you typically would do your CT scanning. So with the edentulous arch, we have something that we refer to as a dual scan protocol. And this is pretty common across the board with companies and laboratories that are working with this type of protocol, these type of digital workflows and analog workflows for full arch. So dual scan protocol with an edentulous arch, not necessarily totally edentulous patient. What we need is, first off, on the dentures you see here, we need 6 radiographic markers. We're looking for 3 of them out on the buccal. We're looking for 3 in the palatal or 3 in the lingual. And what we're wanting to see is that on the buccal, we want to have that. This is this type of radiographic bead has a sticker that this is a little radiographic bead right here. These are very nice. Suremark stickers are one of the companies that make these, that you can place that BB somewhere around the first molar area around the cervical of that molar, one out near the cervical of the centrals, and then on the other side as well. The important thing is to offset your the lingual or palatal beads from the buccal. You don't want to have one bead right here and another one directly opposing that, because when it comes up in the scan, the laboratory, when it comes up in the zip file and the laboratory opens it up, there's all these scans that they have to extrapolate between the STL files and the DICOM files. And they're using, if you will, like an XYZ reference point, 3 reference points to capture those scans and line them up with opposings, line them up with other data so that we know we have reference points to just do, again, our cross-validation. So it's kind of a triangulated pattern, as you see here. Additionally, they do have these scan markers that are like a breathe right strip or like a butterfly Band-Aid, and they're made for average size of centrals. They make them for average size of laterals, canines, bis, and molars. What's nice about that, as you see in this image here, the scan, the X-ray, the tooth, the denture tooth is just stark white outlined. So if you were to say to the laboratory, communicate to the laboratory that you wanted, patient wants their teeth 2 millimeters out more for more lip support, or they want it back, or they want them longer, they want them shorter. We have very accurate measurement validation from this image here as to the bone image, from the incisal ledge or the facial to the alveolar ridge. So we have these reference points, so we can be very precise in moving those teeth based upon what your preference is. The other thing that is very important to do, and you need to do it probably most of the time unless they have a very new denture, and that is to do a reline of that denture for the scan. Doesn't mean you have to have a lab processed hard reline. What we're meaning here is to, as a minimum, to do like a PVS wash impression. Most polyvinyl siloxane materials have some radio-opacity to them, radio-opaque to them. As you see here, this white, this opaque area is all impression material that really helped out during that scan. One, it stabilized the denture for the patient, because a dual scan protocol, you're scanning the patient with the denture in the mouth with the markers. And in my next slide, I'm going to show you, you're going to scan the denture by itself in your CT unit on a box or maybe on a table that is provided by your manufacturer of your unit. So if a patient shows up and they have their Fixodent material or whatever type of adhesive in there, just know that you need to do a wash impression on that. Clean out the material. Do not use tray adhesive, because you want to just pull this impression material out after the scanning's done, and then you can give them, put some fresh adhesive in there and dismiss the patient. But it's very important, because now when we scan the denture by itself, you're going to pick up the anatomy from, as you see here, we're scanning the denture, you are scanning the denture, I should say, by itself. So you're picking up the anatomy in the mouth from the scan, as well as picking up the anatomy, the alveolar ridges, I should say, of the entire arch through the scan of the denture. It does not matter if the teeth are up or down when you are scanning them on a box, but just imagine that has to be positioned in your CT unit the same as if it was in the mouth. So you don't have to use these stickers, of course. If you have another technique for radiographic markers, gutta percha, some will still use some radiographic BBs, and maybe drill it out and glue them into here, into the denture base, whatever your preference is. But just keep in mind what we talked about. We're looking for those, at least 3 of those markers. So we're going to talk about capturing the video and recording whether you're recording CRCO, as I mentioned earlier, we need to know what vertical do you want this patient to be, you're going to restore this patient at. and we need to have their occlusion established. So that means that some of these cases you're working on, keep in mind, many of these patients do have broken down dentition. They have a collapsed or closed vertical. So when their CT scan is taken, that needs to be done at the patient's desired vertical for the final prosthesis. Now, that might be a little bit of a mind shift, paradigm shift for many of you, because you're thinking that, well, we're going to open them up with the, with occlusal rims or the denture themselves or the bridge themselves. And keep in mind, this is immediate load protocol that we're talking about. We're going to load a complete arch or arches, if we're doing a double arch, at the day of surgery. So what happens is that patients that have a collapsed vertical and you're going to open the vertical, many of these patients need to actually be in splint therapy for 4, 6, maybe as much as 8 weeks to deprogram the musculature and reprogram the musculature to that new vertical. In other words, actually be able to stretch those muscles to tolerate that new position. And this is very important that you have you make this decision in your very early consultations with your patient. And the reason I say that is because we hear many times that the patients may be thinking about this, talking to you, the clinician, about doing this procedure. And maybe a year goes by and finally come in and say, you know what, doctor, I'm ready to do it. Here's my check, let's go. And then all of a sudden they say, by the way, I'm really excited because next month my daughter's getting married, or my son's graduating, or we're going on our dream vacation and can't wait to have my new teeth. And you're going to break some news to them, because especially if we're trying to open these patients more than 2 to 3 millimeters in the posterior, you really need to have that patient in some type of splint therapy, deprogramming and reprogramming that musculature. If you do not, here's what can potentially happen, is that the patient, day of surgery now, implants have been placed, the temporary provisional, the long-term provisional has been fabricated to the desired vertical, the open vertical, and now the patient's been edentulated, let's say, and they've lost a lot of proprioception. And now we have, freshly placed implants. Hopefully we have that good 30 plus newtons of centimeters insertion torque on all the implants. And especially if we have more than 4 implants, that's even, that's better yet. But the patient can really put a lot of biting forces and really not be that aware of it and cause failure to the implants because of some people might even call it almost like it's parafunctional habits. That's just because their muscles can't stay in that position, keep wanting to go more in a closed position. So what we've also have found is that in some training that I've done through full mouth reconstruction, just through nathology, not with implants, but just in natural dentition, is when you are opening a patient up, it's 1 millimeter over the first molar. If you open a patient 1 millimeter in the first molar area, equates to 3 millimeters in the anterior. So 1 to 3 ratio because of the arc of opening or arc of closure. So keeping that in mind, opening some patient 2 millimeter posteriorly is going to be 6 millimeters in the anterior. But you get more than that 2 to 3 millimeters, you really should be working off the patient, locating the patient's hinge axis, and functioning from there. So you don't put the patient into some type of a temporomandibular joint disorder and cause some real problems for your patient. So keep that in mind. Splint therapy may be needed. I will say this, at least with in Sequence Laboratory, when we receive the scan at that vertical, we're comfortable opening or closing a patient's vertical from the scan that we receive no more than 1 millimeter in the posterior, which would be 3 millimeters in the anterior. The reason for that is in some software, the way that when you're opening it, it doesn't open in an arc the same as an articulator, or especially same as going on in the patient's own condyle area. And more than that 1 millimeter, we found that if there's potential error with the trajectory of that, that we could actually have implants start going at angles that were not planned. And that can be a problem. As I mentioned earlier, that when you have a very narrow ridge, you have to be very accurate and where those implants go. And we need to give you that accuracy within the surgical guide, which all comes from the records that we're receiving. So keep in mind that you may need to have a patient's vertical open to make sure that they can tolerate it. Because just think about that. If now you're in splint therapy, you're out at 6 weeks, and the patient just cannot tolerate that, which you thought you could do that. And now we got to really be thinking about, okay, what vertical can that patient tolerate? And we'll scan at that and have more conversations with the laboratory, because our conversations that might be talking about bone reduction, maybe additional bone reduction based upon the prosthesis, the final prosthesis that you're looking for. Say if you're doing a hybrid titanium bar with denture acrylic and denture teeth, that type of a prosthesis requires the most inner arch space. Inner arch space is measured from the platform of the implant to the occlusal plane. And often that's also could be, you could think of that as being from the plane, from the level of the alveolar ridge to the occlusal plane. Because typically, most often, the platform of the implant is going to be placed at the crest of the ridge after bone reduction. So we figure all that in. But we have to figure out the bone reduction to accommodate, one, the transition line, to hide that line. The other is to make sure that we have enough room for the final prosthesis. So that acrylic hybrid titanium bar with denture teeth can require 15 to 16 millimeters of inner arch space. We like to plan for 16 in the anterior, tapering to 14 in the posterior. So that's quite a bit of room. If a patient has a collapsed vertical, that helps in that scenario. But if you can't open the patient up, then those are the issues that we have to be addressing and be thinking about here. Everything I'm talking with you right now is all pre-surgical. We haven't, you're not committed to anything. We're still planning the case out. So this is how in depth that we need to go in evaluating these cases to make sure that you're going to have success on the day of surgery. So making sure that we can, if the patient can't open that, now we had splint therapy, you find out you can't get them to that vertical. Well, a zirconia prosthesis, monolithic zirconia, we're comfortable going to as short from the platform of the implant to the occlusal plane to about 12 millimeters. So that's pretty significant, about a 4 millimeters difference in vertical. So that could be your solution for the patient. Now, those types of restorations always cost more. A zirconia, just about 99.9% of the time, is going to cost more than the hybrid denture teeth and acrylic with the titanium bar. So again, in the planning stages, this is where you want to be careful to commit to a patient of what you're going to deliver. We need to, let's get these records. We're going to talk more about the restorative options at the end of the presentation. I really want to spend time here because my real goal and our goal as a laboratory, as a company with this presentation that we're doing, this webinar, is to really tighten up some of the loose ends that we seem to still happen at times. And, surprises are not good in implant dentistry. I've been doing this for over 40, in implant dentistry for pushing 30 years now, but a technician for over 40 years. And I don't know of too many good surprises. So we try to avoid surprises. And this is how we do it, is doing the due diligence up front, doing the legwork, so to speak, here. So you have a patient that's fully edentulous. They don't have a denture, or they're edentulous in one arch. They don't have a denture to use with scan markers. You don't have to make them a new denture, but you do need to have very accurate occlusal rims. What you're seeing here is the occlusal rims. We're asking to mark that high lip line. That's the high smile line, as high as we can go, that Duchenne smile that I was referring to a little bit earlier. Always mark a midline on occlusal rims. Just another reference point, a checkpoint for the lab. Mark that midline. What you're seeing, these other marks here, that's the center of the canine. That's where your buccal corridor begins. So that helps with arch form. It helps with mold selection, to have something that fits properly in that patient's arch if we don't have study models or references of natural dentition to go by. Is to get it even at least 2 central denture teeth placed in there to really see that, so a patient can see that the length of the teeth, maybe even do a little bit of the FNS, have those 2 teeth in a proper position, the centrals at least, labiolingually and incisally. You can see their smile. And again, that FNS position, a little bit of phonetics possibly, checking that out. So we already mentioned here that, scanning a patient, splint therapy for a patient with a little bit more than opening the vertical more than 2 to 3 millimeters. So here's another scenario that happens very often, is that we'll receive either scanned impressions or physical impressions or models. And the patient could be edentulous, say, in one quadrant. What you're seeing here is a patient being edentulous, is edentulated or edentulous in 2 quadrants. What the lab will not do is, we cannot guess at the patient's bite. In other words, if you had some anterior teeth, maybe you have a first bite, even a second bite, and you're kind of looking at it, and say if you had the models, and you could go, well, line up this wear facet here, this wear facet, and you rotate, oh, there's my vertical, right? That's it right there. We don't do that. We cannot guess at that, because we could put your patient in harm's way if we make an error, or if we allow you to make an error doing that. So what you're going to be asked to do is either do occlusal rims, as you see here. If it's just one quadrant that's edentulous, and maybe you have a first bite, a putty bite might suffice as that vertical stop for us at the laboratory that you physically would send in to the lab. But we need to make sure that we get the bite correct. We are going to pre-select the multi-unit abutments, or based on implant systems you're using, some are referred to as SRA abutments, screw retained abutments. So, but it's the transmucosal abutment. The multi-unit abutment is probably the most common phrase for it. The select the correct height of that. We're going to customize the height of your temporary copings, your temporary sleeves. So you don't have to do that the day of surgery. But the only way that we can do all these things, and we're going to make the bridge, hopefully, to the spot-on occlusion that you're looking for. We can only do that when we have accurate records. So when you don't do accurate records, you're not going to enjoy the benefits that this type of technology and treatment modality can offer you and your patients, on that day of surgery and even thereafter. So if you do have a quadrant that's edentulous, keep in mind about a scan marker. So here you see a little scan marker was placed. So let's just say this patient had dentition on the left side. So we have our XYZ. Our X could be this scan marker, Y could be a central tooth out here. And then, Z could be maybe a molar on the other side of the arch. So just give us, the more information you provide to the laboratory, it's in your best interest. So when we ask for things, it's not, again, it's not we're trying to be greedy or cause you more work. It's really to make sure that you and your patient have good experience on the day of surgery. That, once we receive all your information, I mentioned really early on that we work in both a digital world and an analog world. And I say that because when you do send analog information, if it's an impression, we're going to pour the model. We also will scan impressions, scan the models. We're looking for as much information as we can get. But if you send something in analog, we digitize it. What you send in digital, we print it and we turn it into analog. This is that cross-referencing, or I should say cross-validation that we're doing that really helps us to provide you, once again, I know I'm sounding like a broken record, but having done hundreds of these cases chairside, and we've had cases that go so fantastic, and we've had cases that don't go as well. And sometimes it's not the clinician's fault, and it's the patient, and it's not even the patient's fault. It's many reasons that things can be challenging during these procedures, the day of surgery, even for your record taking. Sometimes they can be challenging. We know this. Your patients sometimes they haven't seen a dentist in 15, 20 years. So this is not for everyone. I should also say this. Look, I really appreciate y'all being on this webinar and learning about this information, but if you don't really feel comfortable with this, know enough about it to refer it out for you and your team to have conversations with your patients. It's a wonderful treatment modality. Patients have a right to be given this option, but it doesn't mean that you have to be doing it. But I think it's a great idea to be a part of that team, whether you're referring out as a restorative doctor. Maybe you get a prosthodontist involved with you in your first few cases. Those of you doing the surgery and the restorative, maybe you work with a specialist on the first few cases. This is a lot what we're doing here. This is probably some of the most comprehensive dentistry that can be done until you get into trauma type cases and things like that our specialist friends get involved with. So we just want to say what we do with this information. Then I mentioned this earlier, we're going to go through your CT scan, and they're going to segment that. They're going to go slice by slice and determine where the bone stops and starts and things like that. We're going to do the smile design. So based on the information that you're giving us on the prescription, we'll create the smile. So, and then we're going to create the plan. How many implants? Where are the implants going to go? We want to know, what the final prosthesis is going to be. So there's a lot of information. Our design people, technicians, know about AP spread. They know about cantilevers and things like that. So we're going to set up the case for the optimum results. So once we get your information, it goes into the laboratory, goes through segmenting and all those other steps that I just mentioned to you. The next thing is going to be you're going to get an email invite, like a open table invite to on a calendar to reserve time for an online meeting. And this should be with both if you're doing this in the team concept, this is for both the surgeon, implanting surgeon, and restorative clinician. I really recommend even having your key assistant be a part of this. Have your laboratory be a part of it. You can share the invite with the people that you would like, so that they can kind of really feel like they're a part of this. And so you can do these meetings at the comfort. Many times you're doing it, maybe it's during your lunch hour, or because of your time zone, you might be doing this in the evening. So I'm going to take you through quickly now what one of these online meetings is like. We refer to it as commonly right now it's utilized with the GoToMeeting. So imagine right now that you're on your laptop, your computer, your desktop, and the meeting started. So one of our design technicians is going to be sharing with you. Some of them start showing you the bite. Here I have it muted. And they're going to say, okay, doctor, based upon the information that we received, this is how the articulation has come up with your model. And then based upon what you've said in the prescription, looking at the photos, etc., then we're going to show you the smile design that we're looking at. And what's so important here is that if you see something that's not quite right, or you question anything, ask the question. Please do not just sit there and go, well, they do this all the time. They're the experts on this. They know more than I do about it. Now, yes, maybe they know more about the software and things. You are the clinicians. You're the ones that are, being held accountable by your patients. So in other words, I'm stopping at this and talking about this for a reason. Many cases that I go into, and some of our independent chairside support team, and even our clinical sales specialists that go chairside, they do a lot of chairside cases. The restorative doctor may look at the new smile, or look at it and say, well, that's not what I was wanting. I wanted the midline over here, or I wanted it longer, or I wanted this or that. This is an opportunity right here. You can ask them to pause, stop, rewind it. I have to look over to get to my button here to do the rewind off my monitor, sorry. But they can show you, and if that's not what you're looking for, talk about that and say, okay, I want the teeth further out. So that you see the white is the new bridge, the brown is their existing dentition. So we're going to just go ahead and move this forward a little bit now. So you talk about that. And then next, or one of the things, again, it's not always in this sequence that what's discussed, but now we're going to talk about the bone reduction here. And so based upon the prosthesis that you're going to be utilizing for your final prosthesis, we have to create enough space for that. And so what we're doing is we're wanting to make sure that you're seeing this now. So here you see the bone for this particular patient. The orange is how much bone reduction is going to be required for this particular patient. Now, I can tell you this, that the average patient, the average bone reduction that's required for a patient with terminal dentition, the average is about 3 to 5 millimeters of bone reductions required to meet those restorative inner arch space for the final prosthesis. So an edentulous patient that's been wearing a denture for many years may not need very much bone reduction at all, maybe just enough to just flat. Prosthesis can not have any type of an overlap or concavities, but be more almost slightly convex for hygiene purposes. So having a nice anatomy on the alveolar ridge, not having real high points, that's going to create either a very bullet point type of contact to the ridge, but to have a little bit wider ridge and not have concavities within the prosthesis, have more of almost a convexity for hygiene. So if you, now clinicians, our surgical friends, or any of you that are doing the surgery, sorry, if you have an issue with this, the amount of bone, if you're not comfortable with that, now's the time to talk about that. They're going to show you how far back the bone is going to be reduced. You can see kind of the outline here, the shadowing of the extraction sites. So if you're not happy with that, again, say something, talk about it. We can make the changes here, but there's limitations based upon what your need or what we can do. Keep in mind, you make the final decisions on this. Our job at the laboratory is to provide you the information to make the best informed, intelligent decision that you can make. So because we're showing you something, don't think that it has to be that way. Question us, challenge us, just make sure it's what you want. So here what you're seeing now, this particular case, 6 implants, we've already placed the implants. We're going to go and we look at the best bone quality. We're going to look at, based on the implant design, what the manufacturer using. We can work with most of the name brands that have the ability with a fully guided kit to control depth position and control rotation position. So it needs to be a guided surgery kit. A guided surgical kit means that you can control the depth of the implant and the rotation of the implant, the timing of the implant. That's required. And it may surprise some people that some of the other systems that are fairly popular out there actually don't have some of those features in their guided kits. So if you're ever questioning, you can talk to one of our clinical sales team members and they can help you with that, or reach out to the laboratory. So what you're seeing here is based upon what we've seen. We are able to look at the bone quality through the scan. Our software is able to indicate that for us. Now, as a clinician, you may have put say you put 4 implants in there. And at the go-to meeting, you might see where we put 5 in there. And the reason that we did that is because we saw where maybe the bone quality was quite poor, and maybe because of the ratio of bone to implant interface might be a little bit compromised some, that knowing what we know, again, we've done this for many years, we don't charge more for having 5 implants versus 4 or having 8 implants. the fee's the same. It's just going to cost more in parts and more in your implants and your prosthetic components. But you need to be designing these cases to meet those patients' expectations, which are typically to last a lifetime in 2 days, I always say. They have a high expectations of this. So again, you're in control. If you don't want 5, or, we may talk to you at the time of the meeting and say, doctor, we have it set up at 4, but here's what we think of. And in literally in real time, I'm going to go back to having this run now, and it just about in real time, they can add an implant, move implants. If you want a different position of your implant, you can say, move the apical of that implant more to the lingual. Do this, do that, rotate it up. Let me see where it comes out. The screw access hole, does it come out in the occlusal table, or does the screw access hole, is it coming out outside of the occlusal table? You're doing an FP1, a fixed prosthetic 1, more of a crown and bridge type of restoration. You don't want screw access holes, or you don't want temporary sleeves or the abutments in an embrasure. You want them within the confines of our tooth. So these meetings are your opportunity to really fine-tune the case to meet your expectations and your patient's expectations. So the meeting now has been completed. Everyone's in agreement. Our surgical friends have said, yep, you guys, it looks good to me. Restorative doctors, you're seeing what you're looking for. Everyone's happy. Then the next phase is going to go into the actual production of things. So here's where you're going to your customized, surgical guides, prosthetic guides, all the components. The implants that you're going to utilize for the day of surgery, based upon what we just went through the plan, you're going to be told that here's the implants for you to order. We do not, and Sequence does not order implants. Implants are also not part of any of the fees that you see from us. The prosthetic components are not included in the fees. So you, clinician, you need to order the implants and also order the backup implants, because we've actually had doctors that are kind of dabbling with this type of technology, and they're planning on 4 implants, and they borrow a guided kit and they buy 4 implants. You owe that to your patients to do that. You owe that to the profession to not give us all a bad name by trying to minimize investment in doing these type of protocols properly. And it's really all about the patient at the end of the day. So order the extra implants, get a wider one. You see soft bone, we talked to you on a go-to meeting. In your reports you're going to get as well, you're going to get the reports, a PDF of the report. It can be emailed to you. It's going to come printed in an envelope. I'm going to talk about that shortly here. But you're going to have the information. And, when you have softer bone, get the next diameter of implant, maybe get a longer implant, have backups. The prosthetic components. So to be clear, implants are not ordered by in Sequence Laboratory. That is something that you order. We do order the prosthetic components, the SRA abutments or the MUA abutments, the temporary copings, the low prosthetic screws. We will order them on whosever account that you indicate on the prescription, who's paying for that part. If you're doing a team concept, surgeons or specialists, you need to decide between you and your restorative clinician who's paying for what, how you're splitting that up. That's not for us to dictate to you in any way, shape, or form. So who's ever going to pay for the prosthetic components will ask for that account number. We will call up that implant manufacturer. We will order the parts for your case, the multi-unit abutments and the copings for your case. They will ship to the laboratory directly. It's called direct shipping or drop shipping. You will be billed. You will receive any discounts that you get right now from your implant manufacturer. We do not mark up any of the parts. So that's kind of a different mind shift for many of you that have not worked with us or worked with this type of technology. We don't mark parts up. So, we're pretty transparent on those things. So let's keep going. Let's talk about what are you going to get now? Well, you've done all your work to get us the records. And let's see if Jeff can go the right direction here. So this is all going to be shipped to you. And it comes literally in a styrofoam insert. that, oh, sorry, I got a little blurred vision going here. It's in a box that I'm not gonna be able to get it to you very good. Sorry. I just found that out when I started the meeting that I can't show you things when I have my background blurred. Apologize for that. But we will have everything labeled in little denture containers, crown boxes, as you see here for the components. Everything's been customized. And so let's take a look at what you have. So we call this, refer to it as phase one. Phase one is what is everything is leading up. The records are all leading up to phase one, and that's the day of surgery. Additionally, if you're doing this for the first time with us, what's required, and you're going to see all this coming up, so you may not know the terminology about a bone foundation guide, but we do have a framework that needs to be fixated right to the alveolar ridge, to the bone, onto the bone, utilizing these referred to as anchor pins. Some call them fixation pins that will anchor that. We needed to be consistent. We're using a metal framework now. We're trying to keep everything very minimal in dimensions. And so we've gone with a 1.5 diameter drill, also what should equate to the 1.5 diameter pin. And the drills are a 20 millimeter length drill. On your first case, they will ask you, well, they should ask you in all of your meetings, do you have the anchor pin and the correct drill? We will give you your first set free. After that, either you can order them or we will order them for you, but you do need to make sure that you have these three anchor pins and the appropriate drill to go with these anchor pins. All right, so let's look at what you got in your kit. So what you're going to get in that box is going to be a printed posing model, the working model. It doesn't show here, but if you can kind of tell, the base of these working models, actually there's a magnet to it. You can actually articulate these. When you fill out your prescription, there will be quite a few different articulators, semi-adjustable articulators that we have in inventory. And so we can use the mounting plates appropriately for what you have at your practice. That way, when you get the case, you can actually mount the case and do what we refer to as a dry model surgery and try everything out, which is kind of a nice thing to do. So let's keep going here. You're going to have a pre-op model. This is the way the patient's going to present at the day of surgery. This pre-op model fits on top of the working model here. We'll show you all that coming up. This is really the key to the system. This is the bone foundation guide. This is, once this needs to be placed properly, everything then is predicated upon this bone foundation guide. We're going to show you clinical video snippets, how to get that in place and everything coming up. Then there'll be a mono strut. We use either a tooth-supported mono strut or a bone-supported. I'll explain all that. And then there's something called a bone cut model. This is a representation of how much bone will be reduced to meet the transition line requirements and to meet the requirements of the final prosthesis. Still more coming in your kit is the surgical guide. We call rotation guide to help you line up the correct angulation position when you have angulated abutments, i.e. angulated implants. You're going to receive a tissue gasket, which is going to act as a rubber dam to protect the surgical site. The start bite, we'll talk about that as well. Then you're going to get actually two long-term provisionals. One the patient's going to leave with the day of surgery, assuming we get everything right and we're able to load the case. The other is going to be picked up the day of surgery as well. That's a combination of a backup prosthesis, but we're going to share with you a little further on in the presentation that is going to be utilized for helping you to minimize the restorative appointments to make the final prosthesis. It can save a lot of appointments for the restorative doctor. And then you're going to have a crown box for every implant site to be labeled with, once again, your multi-unit abutment, 2 temporary copings, 2 prosthetic screws, and then we'll customize some blockout plugs for you. The provisional itself is fabricated. The teeth are fabricated, milled from a puck of PMMA, polymethyl methacrylate. So they're monolithic. They're all one piece. The bridge itself is printed from a carbon printer utilizing the Dentsply Lucitone material as a hybrid material that's designed for this type of technology. So we will print the base, and then we bond the teeth to that base, and it is a tenacious bond. With that, we see very few breakage of denture teeth. I'm sorry, it's not a denture. That's why we don't see denture teeth breaking, because the teeth are monolithic and they're PMMA, so they're very strong. Additionally, you're going to receive an envelope that is going to have about 20 some pages of information. There's going to be photos of your case that we've taken at different stages. There's going to be reports to look at. There's going to be charts to look at, drilling sequence based on your implant system. I wanted to take a moment and show this to you. Many people don't realize the value of this bone density chart. And for each implant site you have, this is an 8x10 page that is stapled in with your whole report. The software utilizing is referred to as RealGuide. Within that, this is a page for tooth number 21. What I'd like to point out to you is that there's a square box here, green and red box. This represents a slice of bone. And this particular case, this implant was a 4.6 by 15. And what we're looking at here is we're looking at the three images, these cross-sectional images down here on this page. The center image is right at there's a slice taking right out at the center of the osteotomy. The image to the left is 1.5 millimeters mesial of the center of the osteotomy. The image here on the right, the other cross-sectional image, is 1.5 millimeters distal to the center. Typically, I just say, focus on the center image right here. I blew it up here on the right so you can see a little bit better. But what you're looking at, this chart, it may not show up real well, but it will on your report you'll have in your hand. The D1 bone, there's a dark green, and then it gets, there's a green, and then there's a delineation here. There's a line where now it gets even darker, and that's what we'll call the D2 bone. And then when you get into the magenta color, that area here is D3 bone, and then the brighter red is D4 bone. What you're seeing in these lines, the straight line is the average bone density. I really would like to encourage you just to focus when you see the curved line like this. What that's going to do, the software reads the opacity of the scan and determines kind of the bone density that way. It's not 100% accurate, but what I found is that gives you a pretty good idea of bone changing in density. In other words, this, as I mentioned, this is a slice of bone. This was a 15 millimeter implant. This is 15 millimeters of bone. This is the crest of the ridge right here. This is the crest of the ridge, as I mentioned. So, right, this is the crest of the ridge. This is where this bone here is the apical of where that implant's going to go. So imagine, I see proportion of that implant's taller than that bone chart, so don't get confused by that. So this particular patient, this site, 21, the bone was D2 about halfway down, and then as you can even see in the scan here, it's very translucent or non-opaque, and that's telling us that's soft bone. Well, I like to transpose with Sharpie the big letters. I write the implant size. I kind of covered it up here for patient privacy, if you will, but it'll have the size of the implants and everything right up. This is a straight abutment. Maybe it's a 17 degree or 30 degree. Some companies have different platform sizes. You could write the platform up here, stop positions, etc. But what I want to point out here is that when you see this blue line here is outlining the bone, and this is the top of that is the bone cut, which is actually what we're talking about here. That's the crest of the ridge after bone reduction. Obviously, the yellow is your implant, orange is the multi-unit abutment, the pink is the bridge, and the white is the teeth. But this will help you to decide, maybe I shouldn't follow the manufacturer's drilling protocol all the way because this bone is really soft here. So what we did for this particular patient, we did a 2.0 to depth. We did a 2.5 to depth. Well, it was a 4.6 diameter implant. So the clinician elected to go to a 3.2 implant we went halfway to depth and tried placing the implant. My friends, please remember this. You can always take more bone out. We can't put bone back. And many mistakes the mistakes I see that are made in the drilling protocols is you'll try to do this really fast and you're going to drill all the osteotomies at one time. That really is a mistake, because when you do that, and if you drill all of them the same depth, and you don't realize tactically, you can't always feel what you can when you do it free-handed, or you're doing a single tooth surgery, something like that. When you're drilling through these guide sleeves, especially if they have some drilling guides, and then you have the sleeves of the guide sleeve itself and the surgical guide, you lose some tactile feel for that. So you need to do, I always like to say, look, you have your clinical experience, your tactile feel is one. You have, look at the bone coming out of the drill. Is it white? That's your D1 bone. Is it bloody? That's a D2 bone typically. Is it like a slushy? That's typically D3. If there's no bone, maybe that's D4 bone. So it helps you between looking at the bone, tactile feel, look at this bone chart, and this can help you to make the decision. So the decision was to only go halfway. We placed a 4/6 implant, and we got over 40 newtons of insertion torque. Had the clinician gone all the way to 3.2 to depth with that, it may not have been that high. And then especially if it's a terminal implant, let's say, maybe now you didn't get enough torque here, you can't load the case because you only had 15 newtons instead of that 30 or 40. So our options are to either cut off the cantilever from the bridge, which it's not the end of the world, but patients sometimes can be disappointed in that. But if it's the terminal implant and others, now you're into a denture, and that could be a very big disappointment. So hopefully this helps you, because I find it to be extremely valuable. And I know surgeons sometimes you just kind of glance over that, but I really encourage you to think about this maybe the next time, because it's there to really help you to make those good decisions. Okay, let's get into surgery, the good part here. All right, day of surgery. Surgical setup's all set up here for the patient. To the side in that same room, or maybe on a mail stand just outside the room, are all the components. We like to float them in just some cold sterile like chlorhexidine material. Here's a little bit of a lab setup to finish the prosthesis with. So this is a snapshot. I'm just going to jump over it because I'm going to cover all these. Basically, it's about 10 steps on the day of surgery. All these charts that you're going to get in this envelope that I mentioned, here's those bone density ones. I personally think it's a great idea to tape them up in the room. And as I mentioned before, and I showed you, put Sharpie marker right in the implant size. That way, doctor, your head's down in there, you're looking at the patients, and you can say you're getting ready. Okay, now what was number 21 again? Or what was 8? What size? Anyone in the room can look up and say, that's a 3.8 by 10 or whatever the dimension is. So it's good to have that information at a glance. All right, so let's take a look at our patient. So the patient presents. This patient did have a bit of a closed vertical. The clinician's decision was, instead of trying to open the patient's vertical, was to do more bone reduction. So what I'm going to show you is pretty aggressive bone reduction for this case. I actually wanted to show this. It's not your average case. So I just wanted to, that's my kind of disclaimer here, if you will. So the first thing you want to do, and for my surgeon friends, this is something that gets missed very often. And hopefully in the next couple of minutes, you'll really understand the value of why we want to have this start bite done prior to sedation. So what do we mean by a start bite? You're going to receive in your kit a hard replica that the laboratory fabricated based upon the bite registration that we got, be it digital or analog. We're always going to make this start bite. This start bite, you want to have the patient pre-sedated. So I usually say to the team and to the doctors is, we're going to do this right when the patient comes out of the restroom, sitting upright in the chair before they're laying down. You take this, it works usually the best if you set this little bite wafer into the maxillary arch and off to the side, hold it to the side. Do not guide the patient into it. Just let the patient tap into it. Some patients don't have repeatable centric. They're all over the place, and this may not seem to have any value, but it does have value, especially when we're doing a bone-supported monostrep. This is not a go, no-go. If the patient's bite is off, It just really is going to tell you that you probably have a little more adjustments on the provisional bridge, so don't be surprised if you have to do that. But it's going to really be important when I get into the monostruts and I share with you the bone supported. And I find so many times the surgeons are not doing this. The patient's laying down and you start to proceed. Some of the times are taking bite registrations at the patient sitting upright. If you lay a patient down, the condyles, they're already so many times in a retruded bite, and this may not be seen accurate because they're laying back physiologically, they go into a retruded position. So we've done the start bite, looks good, you're happy with it, or maybe there's a little bit of an issue with it. Maybe the patient isn't biting correctly. That's okay, we're going to keep moving forward. We're not going to stop the case because of that. So you're going to have 8x10 sheet. If you're doing what we call the two supported monostrut, what we do is we also refer to as selective extractions. We're going to say that you're going to edentulate the patient, except for 2 teeth. We try to retain a couple of teeth when the patient has stable enough dentition to position this monostrut. And you're going to see all that coming up. So now, some people take a Sharpie and put an X on it because you get in the habit of extracting teeth and all of a sudden you need to edentulate the patient. It's like, oh no, we've lost our reference points. So it's a big flap. You're going to lay a very large flap. You have that bone cut model that you can look at. This represents the bone cut. So you're going to have to relieve or reflect at least 2 to 3 millimeters beyond here. So you can kind of hold that up to the mouth and look at that. You have the opportunity here to, again, atraumatic extractions are extremely important. My surgical friends, we know that, you're experts at doing the extractions, but just realize that the guide, the bone foundation guide, is made to fit across the buccal and palatal or lingual bone. And when you're expanding those buccal palatal, buccal lingual plates, it could compromise the fit of the bone foundation guide. We're going to talk more about that. So atraumatic extractions are extremely important. It may take you longer to do the extractions, but this technology, it's not about a race. This treatment modality, I should say, it's really about getting things accurate for the patient. We understand patients, sometimes you have medically compromised patients and you've got to rock and roll. It's your call. I just want to share with you atraumatic extractions. When you do not get atraumatic extractions, be sure and be squeezing that bone back, be ready to maybe grind in some bone, maybe even adjust some of the metal on the bone foundation guide. I'll show you that coming up. Okay, so we're going to seat the bone foundation guide, and that's the metal portion. Well, how do we get this metal portion in the right position in the mouth? Is we use what's called a monostrut, and we have 2 versions of the monostrut. One, as you see here, is called 2 supported. This is one we've just been talking about. You're going to retain at least, we try to retain 2 teeth that are stable enough, and you'll tell us which ones on our online meeting. What you're looking at, this is alveolar ridge. The tissue has been reflected already, so the tissue is somewhere down here. So this is bone and teeth. The monostrut is making contact onto that tooth. A bone supported, this is bone here, but we're going to use the patient's occlusion. Look at the difference. The occlusal of this bone supported, there's teeth there. That's occlusion, the patient's occlusion that we've duplicated. The monostrut, we don't use the occlusion, we use the teeth. So you're going to probably get to thinking of this already. This is where knowing if you have a bone supported, important you know this, how that start bite was, because if the occlusion was off here, then you're going to have potentially be moving this in the wrong position. I'll cover that more coming up. So let's look at the 2 support a little bit more. That's more commonly what we think clinicians like this more than the bone supported when you can do it. So here you're seeing that the monostrut is separate from the bone foundation guide. It's held in a position with 3 pins. And here's what it looks like when it's properly seated. In the mouth, what we're looking at is we want to see these teeth fitting into that guide exactly how it did in the model. And then posteriorly, a little hard to see here. I appreciate that, but the metal of the bone foundation guide, you're going to see it coming up, needs to touch bone. It's bone supported. So we have bone to metal back here, posteriorly on both sides, and we're making contact on those teeth. The bone supported What's a little bit different again about this one is that it's going to be touching strictly on the edentulous ridge. So either you edentulated the patient or they were edentulous at the time of surgery. What we're going to utilize to get this in the bone foundation guide in the correct position here is we're going to utilize the occlusion here, and we're going to make sure that the bone foundation guide is touching bone, metal to bone back here, and the strut is setting onto the alveolar ridge. I like to highlight a little black Sharpie here. So those three ways we're adjusting it in the right position. If you did not check the start bite and the patient was off, let's just say the patient was off on the start bite, but you didn't check it, you didn't know that. Now the patient, you're trying to put them into occlusion here, have them bite into this, and they're not biting into it right. The error comes in, and you're going to maybe try to start manipulating this now into the a wrong position by the occlusion, and potentially you could potentially have this in the wrong position, and that could be a real problem because your implants aren't going to go where they're planned. So I really wanted to reiterate this importance of the start bite. I hear so many times that it's not utilized, and it's going to give you some false information to make some inaccurate decisions. All right, let's get more into the surgery here. So you've reflected the teeth. We're going to go now with a tooth-supported monostrut. The case I'm going to show you clinically is a tooth-supported monostrut. So it's nice to try things in to minimize all the different variables of if you put the metal and the bone foundation guide and the monostrut together for the first time and try to go in the mouth, if it's not seating, you don't know for sure what's holding you up. So let's kind of minimize those potential variables and do this. I find this to be very helpful, and that is to go ahead, just take the monostrut by itself and see how it fits onto the teeth. Now, it also helps to make sure you reflect it enough because the strut here comes down past the alveolar, the crest of the ridge. But what we're looking at here is to look at this case. Look, those two teeth, they sure do. They fit right in there just how they did on the model. That tells us that the teeth did not shift since the scan was done or the impression was made. It also tells us that during the extractions, you as the clinician, you did not fulcrum off of that tooth and maybe shift that tooth. And then what we also have is what I refer to as belt and suspenders. You're going to have two teeth ideally, but we're also going to make one of these struts in between the two teeth contact the alveolar ridge. Why do we do that? That's because what if that tooth shifted since the scan was done or impressions were, and you could extract that tooth that's not fitting, and we still have another tooth here, and we have this monostrut as a guide. So if both teeth, something were wrong, now we're kind of like a bone-supported monostrut. However, we don't have the occlusion to really help you get lined up. So you're really going to be looking at the anatomy, look at the model, go back and forth, making sure the information's there, my friends, for you to look at. You just got to know to go over and grab the model, take a look at the model and compare things. Okay. All right. So we tried in the monostrut by itself. Now let's try in the bone foundation guide by itself. I like to do the monostrut first, then come back and have you try in the bone foundation guide. Here's why. You see it was a big flap, of course, because of the bone reduction. He's tied the flap back here with some sutures. But now look how the metal is making contact over the posterior here. The bone foundation guide's metal to bone right in this area. It doesn't contact 100% along the buccal or palatal. It does not do that because it can't. Sometimes when you still have this bone there, this guide's fitting down below the crest of the ridge because of the contour of that bone, the path of insertion, we have to create gaps here like that to get over that height. But there'll be plenty of areas where that metal is going to be touching bone. So look at the model, how it was. Look in the mouth here. Does that look right? And the reason I do this last is because sometimes you're fighting that flap to make sure it's not in the way. 9 times out of 10, if this is not seating, the flap is not large enough. You've not reflected enough. It's going to be hard for some of you very conservative with flaps to utilize, to do this. You just feel like you're degloving. This is way too much. If it's not fitting, it's usually tissue. Could be, if you have a throat pack there, maybe the throat pack's catching it, and it could be bone from the bone that got expanded. So you get the flap out of the way. You like this, you could either go ahead now and hold it there and attach the monostrut to it, or this clinician, we went ahead and attached it outside of the mouth and attached the monostrut to the bone foundation guide. And now I felt bad about this one, believe it or not, because when we filmed this, it went on too good. It went on so easy. I mean, it does happen, I don't want to make it sound like it never happens. It does happen, but it's the bone foundation guide, I say, can take 5 minutes or may take 50 minutes. Whatever it takes, because everything is predicated on getting this in the right place. So here we go. Everything looks great back. So the next step then is we're going to go ahead and we're going to pin that. So here's that 15 millimeter, 20 length drill, 1.5 diameter, drill to depth. We already did the other 2 pins here. I'm just showing one, holding it in place up against these teeth. And now we're inserting that long anchor pin. And now we've fixated, this guide is in place. Now you're able to go ahead, and the monostrut is done. The purpose of the monostrut is completed its job. And that was to get the bone foundation guide, the metal componentry, into the right position. So now we're going to remove these pins. By the way, we are now using small metal pins instead of these plastic ones. I need to refilm this, which I'm doing this summer. So we'll have all of our updated componentry. So here we are. Now, this is your bone cut model. You can look at it and say, well, I like to do this, actually check it before you drill and pin to see, does that look like we have the same space here and here? Once again, you have a lot of information to make decisions on. Just know that that's what the models are there for. Just please don't leave the models sit in the box and not utilize them. So now you extract those 2 remaining teeth. And the next step now is to go ahead. Many times people will use a back action rongeurs or particulate some of the, remove some of this bone for the, to add into the bone graft, or use, particulate it into the bone graft, or as bone graft material based upon how much bone you're actually able to get. Now, the next step is to reduce the bone flat from the buccal ledge of this bone, the metal guide here, from the buccal flat to the palatal flat. Some people will use a piezo unit. Most people will use a large acrylic burr like this. Some will use like a 557, and we have a long shank burr, maybe come in and undermine that bone, then come in vertically and make some cuts and take out blocks of bone. Some will use a back action saw, a reciprocating saw. But either way, your goal is to reduce the bone until it's flush. We have 2 ways to verify that the bone is flush. One is we'll have this rotation guide. If there's no angled abutments, this is an angle rotation guide for the multi-unit abutments. If there's no angle rotation guides for your case, it will be called, the denture box will be called, it'll say bone cut verification guide. If this doesn't pin in, it just sets in, quick and easy way. If this doesn't rock, there's no gaps here in the anterior, anywhere around, it doesn't rock, you've reduced the bone to the proper, nice and flush. The other option, and a backup as well, is to use a metal probe and touch tip to, go across from metal to metal. If you feel a high spot, reduce that high spot. So now we've got the bone nice and flat. Now we're going to place the surgical guide. The surgical guide then has keys in the same way the monostrut did, with the extensions going up over the bone foundation guide out on the buccal. And then you're going to utilize the pins that are provided. That'd be the same pins that were used for the monostrut. And we're going to secure that surgical guide in place. Again, you're going to receive metal pins now. We still send you 3 backup plastic pins in case you drop a metal one. So we're going to secure the surgical guide with those pins in place. You'll see these markings. We actually put the implant number, the tooth number at each osteotomy, so you're making sure you get into the right place. That blue line that we put on here, that's going to be the line for your rotation, the depth for your timing, if you will, the implant at time of implant placement. The sleeves here are all OEM, meaning they're implant manufacturer sleeves. We don't use aftermarket components. We use all original components. So now the osteotomy, whatever system you're working with, you're going to create your osteotomy. You're going to place your implant through the guide. The implant, the guide sleeve is positioned to where the placement mount, when it's seated, will have the depth control is by the diameter of the placement mount to the sleeve. The timing is what you need to control by watching the rotation. Some companies have dots, some might have vertical dots. Many will have like a hex, a flat, and you would just bisect that flat with that blue line right in the middle. This is getting the timing exactly the way it should be. What I mean by that is putting a flat of an implant. It's an implant has 6 flats, 60 degrees at each flat. So it's putting a flat in the correct position. So when you have an angled implant, you're going to put the multi-unit abutment in, as opposed to doing it freehanded. You got to guess a lot, back and forth. Well, that's not lined up properly. It looks this way. It's leaning out. It's leaning in. This way we can control the timing, which makes it very more predictable in seating your multi-unit abutments. Okay, so you make sure that you're to depth and you line up, and now your implant's placed. Once all the implants are placed, you're going to evaluate for bone profiling. Keep in mind, when you have an angled implant, that unless you tell us differently on the go-to meeting, your online meeting, we put the platform of the implant flush to the bone, the highest point flush to the bone. So when you have an angled implant, that means the distal portion of that implant is typically going to be subcrestal unless it was part of an extraction site. So bone profiling, and many companies have their own bone profiler system. Highly recommend you go ahead, buy their system, buy that bone profiler kit. It will really save you a lot of time in the surgery, be very predictable, and getting the bone out of the way to ensure that you are able to seat completely the multi-unit abutment. So now we have an angled multi-unit abutment. Implants have all been placed. We removed the surgical guide, and now we're going to place these multi-unit abutments. Again, with other implant systems, it might be referred to as an SRA abutment, screw retained abutment. So here what we're going to see now is the blue line on the guide is saying to you, the clinician, be it the surgeon or restorative doctor, that screw, this little screw head here, that goes into the implant, that screw head needs to point and be lined up with the blue line. Now, we also have the blue line on the bone foundation guide on the back of the metal, but sometimes that is a long distance between the implant, might be a centimeter from the implant and the back of that guide. And guessing that angle, which hex am I in, can be a little challenging. So the angle rotation guide is not mandatory for you to use. It's a visual aid. It just brings that blue line right up where that screw is here to help you get the proper position instead of going eeny, meeny, miny, mo, where am I going now? You also will notice that the carriers are like a fence post. When you look at it from the buckle, they should be straight up and down. And in this next image, you'll see how the driver, well, you don't see the blue line because the driver that's tightening that abutment screw into the implant on the angle is actually right over the blue line. So your driver should be right over the blue line, and your carrier should look like a fence post. That's how you know you get these in the right position. Then placing the straight abutments, for many implant companies, they have a plastic carrier attached to it. Some will have another carrier screwed like you just saw. It doesn't matter. It's whatever your system is. This is just showing where a plastic carrier allows you just to engage the initial threads, get it started, and then just kind of snap that off. And then you would come in with the appropriate drivers and tighten that down to the correct torque. Now, we have all of our multi-units in. You remove the angle rotation guide. Again, it's not mandatory to use. It's there as a visual aid. Now, this is really important. because now the next step is we're going to attach these temporary copings to the multi-unit abutments. Instead of placing all the abutments, all the temporary copings or temporary sleeves, these cylinders, onto the multi-unit abutment, and then coming in and try the bridge on, you will drive yourself crazy trying to find out if the path of insertion if it doesn't seat all the way, where to adjust. It's not uncommon that you have to relieve or open up these holes that we pre-drilled here, because there's a little bit of gap between the mount and the placement mount of the implant and the guide sleeve. It has to have a little bit of a space because otherwise you would cold weld it. And that little gap the implant might find, some of these really good aggressive threaded implants will find they will kick off a little bit, finding the best bone to engage, and they'll be off a little bit. And so multiple areas like that can cause you to have a little bit of reduction needed, or an enlargement of that hole. This particular case, I found this is the actual case. I was a little bit tight here. We were a little bit tight here. We want to see gap or space around this coping or the cylinder and the bridge itself. We need room for the material that we're going to lute and bond that with. So we see that, so you place two, try the bridge on. Looks good, great. Maybe it didn't look so good and you needed to make an adjustment. Well, mark it, grind, adjust that spot where it was hitting. And then on the second bridge, because you're going to have two bridges, go ahead and do that same adjustment on the second bridge. Only takes a matter of seconds to do this. This is important because when you go to pick up that second bridge, you're ready to get out of there. The patient's ready to get out of there. You don't have to keep doing this 1, 2, Z, try one on, try another one on. So keep that in mind. Put two on, try it on. No adjustments, great. Put the third one on, try the bridge on. No adjustments, great. Don't you got 6 implants. Oh, the other ones must be good too. It will drive you crazy because you'll still need to do some of this adjustment. I'm sharing this with you as to help this be a really good workflow with you and to really enjoy what this kind of technology can do for you. All right, so now we've got all the copings in place. We didn't have to pin the bridge in, we just slid it on and off. So now what we're going to do is we're going to put on the prefabricated tissue gasket. So we're looking at alveolar ridge there. We need to protect the surgical site. So we're seating this tissue gasket, and this should be pushed down all the way to the right over the base of those copings. This particular clinician likes to use the bridge to push it down. I still think it's, I kind of like to push it all the way down completely. But here we are. We know that this fits. The tissue gasket is going to protect the surgical site. And now the bridge goes on. The pins are placed the same way you held the monostrut in place, the same way the surgical guide was in place. So are you seeing why it's so important to get that bone foundation guide in the right position? Because everything's going to follow that position. So don't forget about checking that start bite on bone supported ones, my friends. All right, so now we have the bridge exactly where we want it. Now the next step is we're going to bond or pick up those copings. So now we've got everything in place. Whoops, I just hit the second slide here. Repeated the slide. We provide you with blockout pins. Some will be green, some will be red. It kind of depends on the implant system. We have to customize it for the implant system. So these blockout plugs we provide you are going to go into those temporary cylinders, quick and easy. That just makes sure no material goes up in there, because that will make for a non-fun day when you have acrylic there trying to get to those little screws. All right, so now we're ready to pick up the bridge. And I didn't point it out, and I apologize, but you'll see it here in the video. On the bridge, we have pre-drilled injection sites at each implant site. And you use the smaller tips here. This material now is being injected. Use a probe to encourage that material around that coping, breaking any air bubbles. I like to leave a little bead of acrylic out here. You can take your little finger and wipe a little of that excess off. keeps you, it helps with the finishing to make it much faster. Pardon me, much faster. But you just repeat that with all these sites, inject the material. If it's a dual cure, hit it with the light. If it's a self cure, do your timing. If it's a light cure, get 2 lights. It expedites it. At this point, again, we're ready to get everything going. And this is the restorative phase. So you restorative doctors, I hope you were paying attention. Usually the surgeons will stop the surgery, their portion, after they put the multi-unit abutments on. Okay, so now the next thing is to remove the bridge. It's been set up. You have to remove the small prosthetic screws, remove those pins. And if you watch on the right screen, now what you're going to see here in real time, those have done conventional protocols, you're going to see here, your conversion is a matter of just backfilling those little voids here, cutting the arms off and cleaning up on the occlusal. So the first bridge comes out. Now you're going to pick up the second bridge. So what does that mean? You're going to take the second set of temporary copings, repeat what you just did, put all the copings on, put the gasket back on, put the blockout plugs in, redo the luting process. That is going to picking up the second bridge here for your restorative doctors, surgeons. I understand that sometimes the medically compromised patients, you got to get them out of either anesthesia or just get closing. It takes about 8 to 10 minutes to pick up the second bridge. You make the clinical decision, what's best interest of your patient, but please realize that for another 8 to 10 minutes, you're going to save your restorative doctor and your patient when it comes time at the end of for the fabricating the final prosthesis, multiple appointments. Not only appointments, but time. It's going to make it for the restorative doctors much more profitable, busy, and the appointments may be a month apart. So that a final could drag on for 3-4 months. So the second bridge acts as kind of all these in one. It acts as a verification jig. It's going to be used for your impression and so forth. So here's what we're going to do. Now that second bridge comes out. Now we have the availability. We don't have time to discuss it now, but you reach out to your clinical sales specialist and they'll talk to you about chairside support. But someone, either the restorative doctor, a dental assistant, your technician, or someone from our laboratory that you've hired to come out, is finishing up that bridge. The surgeon is placing healing abutments, healing caps over the multi-units, getting ready to do to close, to close. So the next step then is to remove the anchor pins. So this is the first time now that you're going to touch these pins. Remove the 3 anchor pins. And so while this is going on in the next room, we are cleaning, we're finishing up the bridge. I'm going to show that next. I got to go a little bit quicker. So here now the framework, last pin comes out, and we're going to just lift the frame out. Now, our surgeon friends, you're going to go ahead and smooth off the bone, graft as needed, suture around those healing abutments, as you see here on the right. Okay, now here's what we're going to do to finish the bridge. What you see here, all I've done is I've washed off the blood, I've dried it, I've replaced the blockout plugs. So the next thing I need to do is address these areas, the occlusal, buccal, and teglo, and remove these arms. So let's go ahead and do our conversion. So what we're going to do is, and these are running in kind of real time here. You don't have to have a disc. I personally kind of like a disc. Remove the arms. I like to remove the arms first. So cut those arms off. And then using a large acrylic burr, I'll blend where those arms, you don't want to get too much cut off and have a defect there. So we're just taking acrylic burr. Again, the surgeon is closing while this is happening. That's usually about 15, 20 minutes, maybe a half hour. To do what I'm sharing with you right now is somewhere around 20 minutes based on the person doing it, maybe 30 minutes. So we're finishing up on the day of. You just need to get the first one done. So I like to personally, I think the patients pay enough money that they deserve to have a nice aesthetics appearance. I'll take some flowable, matching shade of flowable, put some adhesive here, and flow some of that composite to backfill here. You can use the kind of the matrix, what's left of the teeth here, to kind of give you a guide for reshaping that tooth. It's a provisional, it's a temporary. You don't have to get real crazy with it. You have a technician there. They're pretty quick at doing this and pretty skilled at doing it. So then we're going to come in with some Here now we're just coming in. I like this material. This is a light cure material. It's got a nice fine metal point to it. Now we're just kind of backfilling here. You can kind of see the little gaps that we're just flowing it in and moving right along, because we use a big burr and blend all that. So you finish that portion of it, light cure it, self-cure, whatever material you're using. Now you're going to flip the bridge over. Then the goal here, as you see on the right side, is we want to just backfill those voids. We don't want any undercuts for food trapping. If sometimes these copings stand up a little bit taller above the or above or below, however you want to refer to that, the prosthesis, you make it like an ice cream cone, nice and hygienic, a little taper to it, so you can shape that. This works out real nice. This is, again, instead of a couple hour conversion, shouldn't take more than about 20 minutes or so. So now what we're going to do is we're going to come in and blend everything here. We're blending and smoothing. You get the idea here. Rubber points coming in, stiff Robinson bristle brush works nicely to kind of help blend and smooth everything. Oh, take our number 8 round or 6 or 8 round burr, just kind of open that up so you have good access with your driver to place the screws. Put a little high shine on it. So we're just going to get this nice and high shine for the patient. If you have a lathe or a pumice wheel, that's really nice to have. And then here's the bridge. It's been polished up as best that we can. This clinician actually already had put the screws, the little prosthetic screws in place. The healing abutments have been removed. And now the healing caps, healing abutments, healing caps have been removed. Now the bridge needs to set on top of that. And you'll feel a metal to metal contact, hold it in place. Either you'll attach the screws to the driver. Again, the clinician already put the screws in there. Just now you tighten all your prosthetic screws up. And then as far as occlusion, I recommend just checking the occlusion to make sure that where you've added, that it's not high. The patients many times came and closed back into a normal, their centric or their normal functional bite position. So you can, check their bite a couple days later when they're not numb anymore. And they're, again, they're wanting to get out of here. But I think just to get at least balance out the occlusion so they're hitting evenly on the day of surgery. Then if you're really in a hurry, instead of using Teflon, you can come in with some, this is just some light body PVS, inject it into those holes. I find it's best if you shoot a little air in there to kind of dry that, and then inject some of this material, wipe it. It'll stay in there for the week to 2 weeks that you need. And while you're maybe going to check the occlusion just a few days, you just kind of wipe that with your fingers and smooth it up. And that works pretty nicely. Then here we are, we're ready to dismiss the patient. We can see the trend, it's a pretty hygienic situation for the patient, the way that the tissues have been sutured, the bone reduction, and there we go. So my last couple of slides here. So let's look at the definitive protocol for doing the final. So 4 or 5 months have gone by, 6 months, whatever the integration period time is, you're ready to start the final. Instead of all these steps that are often associated with doing the conventional way, we're going to be able to do your final in as few as 2 1-hour appointments, maybe 3 if you want to have a try-in. So what you're going to do now, the patient shows up, you're ready to take your final impressions. So you can either use the existing backup denture that if you didn't finish it the day of, you finish it sometime in the integration period. Remove about 1 to 2 millimeters of acrylic on the integular side. Do the same if you're doing the existing denture, you remove that denture and do it to the existing denture. Either way, you're going to create some space here, and then you're going to either seat the backup denture with tray adhesive on it, or you're going to seat the existing denture that you took bridge. You took the bridge out, created that gap, put tray adhesive on, and then you reseated. Then you reseat that bridge, which you're going to see in this slide here. So now we've reseated the bridge, screwed it into place with a small tip on of your impression syringe using PVS medium body works about the best. Push the tip starting back in the posterior, push it in underneath the bridge, inject until you see it come out the palate. and then just go in and out as you go around to the midline. Start posteriorly on the other side, go in and out, meet at the midline. You want to look with the mouth mirror to make sure you're seeing the impression material come out on the lingual or the palatal side. Then take and run a nice big bead of impression material over that transition line to capture that transition line. Then that just takes a few minutes to do that. You want to always take a new bite registration and always take a new opposing impression. Those teeth may have changed, chipped, moved, whatever from the impressions that were made 4 or 5 months ago. So take a new impression, a new bite, take any photos. If there's not a lot of adjustment or no adjustment, maybe you could go ahead and go to the final prosthesis, or maybe you want to have a try-in. So let's say anything you want to communicate to the lab, fill out the prescription, take photos again of what you're looking for. Then on the second appointment, you could either deliver the final prosthesis, which is nothing more than taking out the existing bridge and seating the new bridge, or you could have a try-in, and you could request a try-in, and here you're going to remove the bridge, try in your wax try-in with teeth, or you could ask for an acrylic milled try-in. And the acrylic milled try-in is going to be all white, but maybe the patient may be really fine-tuning the occlusion or the aesthetics, and they can wear that for a week or so and make sure everyone's happy. You fine-tune the occlusion, and then take your impression on that and send that into the lab if you need to take another impression of the integular side, or that is your final impression for the lab to scan and make your final prosthesis. Okay, last slide. So very quickly, I'm just going to cover the final prosthesis. We do have this on our website as well. I'm going to show that coming up to you, where you can get more information about each one of these. But really, there's 4 common types of restorations for a final. I mentioned already the denture teeth with acrylic, a titanium bar. Here you're needing about that, 15, 16 millimeters of inner arch space for this. The zirconia, monolithic zirconia can be, they also make now a multi-layered zirconia, which is beautiful. These you're looking at about 12 millimeters of inner arch space from the platform of the implant to the occlusal plane. Nanoceramic is become very popular. The nanoceramic prosthesis, we're looking at about 13 millimeters for the nanoceramic. And then the high-end one that we have is called a thimble bar, where you're actually going to have 12 individual crowns here that are zirconia crowns, individual, on a titanium frame. We create these preps. They can also be done in a material called Pecton. Really don't have time to get into that, but you can Google Pecton and learn more about that. So this is, a very beautiful restoration. They're all very nice restorations. They all kind of have their pros and cons, if you will. We do have additional information on our website. On the homepage, there is a drop-down that says education. And if you go to the Virtual Learning Academy, you can come in here and you can look for, the one that will talk about the definitive prosthesis. By the way, there's my email address, my phone number. Please reach out to me. I'll be happy to get back to you. So thank you very much. Everybody stay healthy. All the best.
Thank you, Jeff, for being here and sharing all your clinical knowledge. We do appreciate it.
Pleasure.
Audience, take care of those patients. And don't forget to tell us how we can take care of you in that survey that's popping up. Good night.
Thank you so much. Bye, everybody.